بسم الله. السلام عليكم ورحمة الله وبركاته. Thank you everybody. We continue our fruitful conference and the activities ongoing. Now we reached the session for the prevention. Unfortunately, always the prevention is something that people are not much interested about, where we all know now prevention is everywhere. In heart failure, valvular heart disease, ischemic heart disease is always there, and the risk factors is everywhere. So our privilege today is to talk about a little bit into details about one of the main risk factors, hypertension. We'll talk about the diabetes, and we'll talk about the other areas. So we'll cover some sessions today to do with prevention. My name is Dr. Ahmed Gabroun, and I have the pleasure to have Dr. Nasruddin with me as expert panel. Our first speaker will be our Dr. Mohammed Hashim. Dr. Mohammed, he is, yes, on the stage, Mohammed? Yes. He will talk about the paving the way, Libya first national protocol for hypertension management. Dr. Mohammed, he has a PhD in medicine in cardiac artificial organ, implantable heart failure assist device. He's also a WHO health system specialist in Libya country office. Thank you, Dr.
شكرا دكتور أحمد. اليوم لي الشرف نكون موجود معكم في البريفنشن سيشن. هنتكلم عن الفيرست ناشونال هايبرتنشن تريتمنت بروتوكول في ليبيا، اللي هو كان بالتعاون بين جمعية القلب الليبية ومؤسسة الرعاية الصحية الأولية والمركز الوطني لمكافحة الأمراض. التريتمنت بروتوكول هو كان معتمد عليه الجايد لاين خاص من WHO واللي هو يسمى بالهارت باكج. طبعا الجهات اللي تعاونت في البرنامج هذا زي ما ذكرت سابقا جمعية القلب، مؤسسة الرعاية والمركز الوطني لمكافحة الأمراض، بالإضافة إلى الجمعية الليبية للطب العام. زي ما نعرفوا الهايبرتنشن هو من أكثر الأمراض انتشارا على مستوى العالم وفي ليبيا كذلك. وفي السابق احنا حتى يومنا هذا ما عندناش دليل إرشادي واضح مخص الوضع في ليبيا، يعني نعتمد على سواء كان الجمعية الأوروبية أو الجمعية الأمريكية. فنتيجة للاختلاف في بعض المسببات لمرض الضغط في ليبيا عن باقي الدول، اجتمعنا واتفقنا الجهات ذات العلاقة أن يكون فيه بروتوكول خاص لليبيا يتعامل مع مرضى الضغط على مستوى الرعاية الصحية الأولية. طبعا زي ما ذكرت WHO دارت حزمة يطلق عليها الهارت باكج، وهي اختصار ل5 كلمات. في التريتمنت بروتوكول هذا اللي استخرجناه اعتمد على 3 كومبوننت من الهارت باكج، اللي هي الاكسس تو اسينشال ميديسن، الهيلثي لايف ستايل كونسلنج، والايفيدنس بيزد تريتمنت بروتوكول. وخاصة اعتمدنا احنا على الكومبوننت الثالث اللي هو الايفيدنس بيزد تريتمنت بروتوكول. في البروتوكول هذا فيه مانوال خاص كيف يهيئ للدول ان هي تصمم بروتوكولات خاصة بها على حسب الظروف اللي هي موجودة فيها. على سبيل المثال في مجموعة من البروتوكولات، أعطي مجموعة أمثلة تخير للمسؤولين على احنا نقولوا في ليبيا اللي لهم علاقة بالبرامج العلمية أو بالأبحاث في ليبيا، يعني تاخذ شو البروتوكول اللي يتناسب مع الوضع في ليبيا وتقيمه. طبعا باش نوصل للمرحلة هذه لازم نعرفوا أول شيء الفرق بين التريتمنت بروتوكول والجايد لاين. هذا فرق بسيط يوضح الفرق بين تريتمنت بروتوكول والجايد لاين. الجايد لاين كيف ما نعرفه كلنا يعتمد عليه على ريسيرش، على ايفيدنس، على ترايلز، على كلينيكال ترايلز، على داتا كثيره. التريتمنت بروتوكول هو ستاندرايزد وستيب باي ستيب، ويعطي للكلينيكال براكتيشنرز والفيزيشن على مستوى البرايمري هيلث كير طريقه واضحه ان هم كيف يتعاملوا مع الهايبرتنشن، اي نوع من التريتمنت يبدو به، وشنو النكست ستيب، وشنو الثيرد ستيب، وشنو الفورث ستيب، وامتى يكون في ريفيرال للسكندري كير. طبعا الليبيان كونتكست حاليا لحد الان ما عندناش جايد لاين لليبيا. في سابق ممكن في محاولات أن يكون في هايبرتنشن جايد لاين، دايابيتس جايد لاين، لكن موجودة وغير معتمدة بالكامل. اللي وصلنا له أن في حاليا عندنا اللي هو هايبرتنشن تريتمنت بروتوكول، يعتبر هو فاليديتد، يعني متفق عليه من جمعية القلب الليبية، وتم اعتمادها رسميا من المركز الوطني لمكافحة الأمراض في ليبيا. طبعا العملية باش نوصل لتريتمنت بروتوكول استغرقت تقريبا سنتين، يعني من احنا نقول اجتماعات بين جمعية القلب، المركز الوطني لمكافحة الأمراض، مؤسسة الرعاية الصحية الأولية. العملية هذه الاجتماعات كانت جايدد عن طريق الهارت باكج زي ما ذكرت في البداية، وكان فيه مجموعة من ورش العمل اللي طلعت احنا نقول اتفاق بين أخصائيين قلب، أطباء صحة عامة، أطباء تخصص عام، أطباء صحة مجتمع كذلك، لأن التريتمنت بروتوكول يكون فيه الكل مشارك بطريقة تكون متناسقة مع الوضع في ليبيا، مع وضع الرعاية الصحية الأولية، وضع المستشفيات في ليبيا والمراكز التخصصية. النهاية كان في عندنا تريتمنت بروتوكول. طبعا هذه واحدة من الورش اللي كان فيها تعاون مشترك بين المركز الوطني لمكافحة الأمراض، جمعية القلب، مجلس الطب العام، يعني كانت أكثر من ورشة بدت من صناع القرار، من وزارة الصحة، إدارة الصيدلة، الإمداد، الاتفاق أن تريتمنت بروتوكول، يعني الآيتمز اللي موجودة في البروتوكول تكون موجود من ضمن القائمة النمطية. يعني في أشياء تبدأ على مستوى الإدارة قبل ما نوصل بها على مستوى الأطباء. فكان هذه النتيجة، أول هايبرتنشن تريتمنت بروتوكول يتم اعتمادها رسميا من المركز الوطني لمكافحة الأمراض. طبعا في اللي يسأل يقول مازال ما فيش منه مثلا نسخ مطبوعة. طبعا في خطأ مطبعي بسيط يتعدل وبعدين حتكون في منها نسخ مطبوعة. فاحنا في 2025 حيكون في لينك موجود بإذن الله في صفحة المركز الوطني، أي حد يقدر يخش على صفحة المركز الوطني ويقدر ينزله. هو عبارة عن صفحة واحدة بالPDF، لكن مساعدة للأطباء اللي بيخدموا في مستوى الرعاية الصحية الأولية. تبدأ عندهم بروتوكول واضح، خطوات واضحة كيف يتم التشخيص، شنو الفيرست لاين اوف تريتمنت اللي نعطيه، شنو السكند لاين، شنو يعني في انديكيشن واضحة، هل نمشي للثيرد لاين، يعني شنو الطرق المعينة اللي نستخدمها. طبعا البروتوكول زي ما قلنا فيه تريتمنت، وفيه ايضا الكونسلنج لللايف ستايل، وفي دايتري ادفايس، يعني مش تريتمنت وبس. يعني الهايبرتنشن قد يكون في مراحل انه يمكن بسهوله انه يكون كنترول بمجرد ما نقص السولت، بمجرد ما نزيد الهيلثي لايف ستايل او الاكتيفيتيز. طبعا مش حندخل بتفاصيل، اغلبكم كلكم هنا متخصصين في القلب، يعني مش حنشرح لكم عليه شنو نعطي في الفيرست لاين، شنو نعطي في السكند لاين، لكن هو درناه بطريقه بسيطه باذن الله تكون سهله للكل انه يقدر يفهمها. طبعا الميزه في التريتمنت بروتوكول ايضا في المستقبل تساعد صناع القرار، الجهات اللي لها علاقه بالامداد الطبي تبدا تعرف شنو هي الادويه المطلوبه باش ندعم أن توفر علاج لمرضى الضغط على مستوى الرعايه الصحيه الاوليه. طبعا زي ما قلت البروتوكول يبدا من ستيب 1 وينتهي لعند ستيب 7. هنا في جدول بسيط، طبعا في اللي بيتكلم بيقول بعض الادويه غير موجوده، هذا تريتمنت بروتوكول للبرايمري هيلث كير، يعني انا ما اتكلمش على السكندري كير او على التيرشري كير. فيفترض ان يكون البرايمري هيلث كير يعني تكلفه اقل من السكندري والتيرشري. مش لازم نحط كل الادويه، لان انا في الاخير مش حنوظف او مش حنسخر كارديولوجيست يكون موجود في برايمري هيلث كير. فهذا علاش التريتمنت بروتوكول قد يكون بالنسبه لكم الفلكسبيليتي في الادويه قد تكون قليله، لكن هي اصلا مستهدفها البرايمري هيلث كير. طبعا الكي فيتشرز للفيرست ناشونال بروتوكول ان الخطوات نتاعها واضحه ستيب باي ستيب زي ما شرحت، ومعتمد يعني من الهارت باكج اللي هو طبعا اساس الهارت باكج يعني جاي من ايفيدنس بيز، من كلينيكال ترايلز. يعني البروتوكول هو طلع من الهارت باكج اللي هو فيه كومبينيشن ما بين الببليك هيلث ريسيرش والميديكال ريسيرش. يعني لما يتلاقوا الجهتين عندي هنا الهارت باكج، وهذا يمكن ايضا يعني الدول كيف تقدر تتمكن ان تطلع تريتمنت بروتوكول، ومع الوقت ومع احنا نقول استمرار العمل في هذا ممكن نوصل لمرحله الجايد لاين ان شاء الله. طبعا زي ما نعرف وقلنا وجود تريتمنت بروتوكول يعطيني فرصة أني نوحد التعامل مع مرضى الضغط على مستوى الرعاية الصحية الأولية. اللي ما يعرفش أنا عندي أكثر من 1000 مركز في ليبيا يقدم في خدمات الرعاية الصحية الأولية متفاوتة بين منطقة ومنطقة. طبعا ميزة التريتمنت بروتوكول هذا سهل أننا نقدر ندرب به الأطباء المتخرجين الجدد أو الأطباء اللي يشتغلوا في مراكز الرعاية الصحية الأولية. أيضا التريتمنت بروتوكول هو يعطيني فرصة حتى لصناع القرار لما بيضع ميزانية خاصة للرعاية الصحية الأولية يعرف أن عنده كمية محدودة من الأدوية ما يقدرش يطلع منها، وبذلك تكون سهلة حتى هم ليهم أن يوفروا الأدوية بإذن الله. التريتمنت بروتوكول هو يعطيني طريقة سهلة أني نتابع أيضا مستوى انتشار مرضى الضغط على مستوى الرعاية الصحية الأولية. أيضا نقدر ناخذ داتا قداش اللي يتحصل في علاج ومن قداش منهم كنترولد ومن قداش منهم ان كنترولد، ويوفر لي أيضا يعني نقولوا فرصة فيها نوع من العدالة الاجتماعية، أن مريض الضغط حتى لو كان بعيد على مستشفى تخصصي يقدر يتحصل على العلاج الكافي أو العلاج اللازم أو الاستشارة الصحيحة اللي تعطيه فرصة أن ضغطه يكون في أفضل الحالات. بعض الجابس اللي تواجه فينا في ليبيا لما نطبق البروتوكول هو أن عندي نقص في الأدوية على مستوى الرعاية الصحية الأولية. تقريبا أغلب مراكز الرعاية الصحية الأولية لو بيمشي لها مريض الضغط بياخذ وصفة ومش حيلقى فيها الدواء متوفر. اعتماد كبير على القطاع الخاص في شراء الأدوية، يعني أغلب المرضى يعتمدوا على الإنفاق من الجيب إنه باش يجيب دواء الضغط. يعني حاليا في وضع وزارة الصحة فعندها نقص في الأدوية الأساسية الخاصة بمرضى الضغط. طبعا الإشكالية الأخرى اللي ممكن تواجهنا عدم الالتزام، يعني ممكن المريض يتابع المرة الأولى في مركز الرعاية وبعدين يتوجه لقسم الإسعاف في مستشفى تخصصي. أيضا الحاجات الأخرى اللي تعيق فينا في تنفيذ البروتوكول هو نقص المشغلات، نقص الأجهزة اللي تعتبر هي اسينشال وبسيطة لمراكز الرعاية الصحية الأولية باش نتابع. فمنضطر للأسف الطبيب في الرعاية الصحية الأولية يقدم تشخيص لكن نقص بعض التحاليل، نقص بعض الأشياء، يضطر أنه ما يقدرش يكمل خدمات كاملة على مستوى الرعاية الصحية الأولية. طبعا البروتوكول يحتاج إلى تطوير وتحديث، ويفترض يكون فيه تعاون إن شاء الله يتحول من بروتوكول إلى جايد لاين. فرصة اللي يوفرها البروتوكول هذا أنه يعطيني طريقة تكون في خطة واضحة من الوزارة، من جمعية القلب، من المركز الوطني، أننا مفروض نستهدف أقل شيء، يعني لازم تكون عندي خطة العدد المستهدف، قداش عندي مريض ضغط نستهدفه بالبروتوكول هذا، قداش عندي مريض ضغط نوصل به إنه يكون الضغط كنترول على مستوى الرعاية الصحية الأولية من قبل ما نوجهها إلى المراكز التخصصية. شكر خاص طبعا لجمعية القلب الليبية، كانت موجودة من بداية المحادثات ومن بداية النقاش في تفعيل هذا البروتوكول. مؤسسة الرعاية الصحية الأولية، المركز الوطني لمكافحة الأمراض، مكتب منظمة الصحة العالمية ليبيا. أيضا في شكر خاص لإدارة خدمات صحية طرابلس، لأن هي كانت من أول الجهات اللي أبدت استعدادها أن تتبنى هذا البروتوكول وتنشر على مستوى مركز الرعاية الصحية الأولية على مستوى إدارة خدمات صحية طرابلس. وشكرا لكم.
Thank you very much, Dr. Mohammed, for this nice and actually very comprehensive, despite that it is detailed, for this second session on the prevention. It is promising actually. So we will move directly to the next lecture that is going to be presented by Dr. Hawad Derby. Let me at first just give her a brief. So Dr. Hawad Derby going to deliver for us a lecture on the updates on primary prevention efforts in Libya. Dr. Hawa, she is Director and Chair of Cardiovascular Division or Department at National Center for Disease Control, and she is Consultant Family Medicine at Al-Badri Golden Poly Clinic. So Dr. Hawa, floor is yours and good luck.
والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه وسلم تسليما. السلام عليكم ورحمة الله تعالى وبركاته. Primary Prevention of Cardiovascular Disease, Libyan Update. I have no relevant disclosure. بسم الله الرحمن الرحيم وأحسنوا إن الله يحب المحسنين. Magnitude of cardiovascular burden, cardiovascular disease is leading global cause of death. More than 20 million deaths annually. Most of deaths are due to heart attack and stroke. 45% of heart attack and 50% of stroke death is due to high blood pressure. The greatest burden in low and middle income country, preventing risk factor is more effective than treating the complication. 37% of death is due cardiovascular disease in Libya. This classified Libya as very high risk to cardiovascular disease. Even in pandemic corona, still the cardiovascular disease is #1 killer. All we know the major risk factor, modifiable risk factor for cardiovascular disease. Risk factor today is tomorrow disease. We don't talk only for diabetes and hypertension. Nowadays, raised blood pressure, raised blood glucose, اللي هو pre-diabetes, is also risk factor and can be modifiable. Libyan context challenge in cardiovascular disease prevention. We have low awareness for healthy lifestyle, no national prevention guideline, limited epidemiological data, interrupted drug availability, unequal access to health care. This is the reference is stepwise and هو مركز المعلومات والتثقيف الصحي. Priority to control in Libya, develop national cardiovascular prevention guideline, public awareness campaign, strengthening primary care protocols, use risk score 2, ensuring essential drug supply, BB medicine and statin, national policy, salt reduction, tobacco control, multidisciplinary committee for non-communicable disease prevention. In response to this challenge, NCDC Libya launched national strategy to combat non-communicable disease. The national strategy have 4 pillars: leadership and governance, prevention, reduction, risk factor, surveillance, monitoring, evaluation, research, strengthening health care service and essential medicine. Leadership and governance أعتقد أعطاها الدكتور هاشم. In 2023, primary health care stakeholder consensus on adapting WHO heart package for managing cardiovascular disease and implemented in selected primary health care. في نفس الشهر صار agreement with stakeholder to adapt standardized hypertension treatment protocol which are part of hearts. طبعا treatment protocol هذا صار updated على أساس European Society of Cardiology Guideline 2024. Leadership and governance also establishment of National Committee for Prevention Committee. In 2023 دكتور عمر مسلم launched Lifeline Initiative، هي طوق النجاة يعني باللغة العربية، for community-based cardiovascular prevention which adopted by NCDC through establishment of Community Prevention Committee for Cardiovascular Disease and Stroke 2023. In 2024, the mandate of committee was expanded to include all non-communicable disease, remained the multi-sector prevention committee for non-communicable disease. Raising public awareness and improving health literacy led organization was Libyan Cardiac Society and NCDC Libya. Implementing public health awareness campaign utilizing multi-channel approach, mass media, social media, school, workshop, workplaces, based program to reduce risk factor. We have 3 major campaigns every year: National Campaign of Hypertension, World Heart Day campaign, Let's Fast Healthy campaign. National Blood Pressure Screening Program in Libya, we have 574 volunteers, 24 cities is involved. هذا فريق إدارة الحملة. We reached more than 8,194 is analyzed data نتاعهم. كان 46 of them had hypertension, 50% of them on medication, only on medication, 16% are controlled. We have a problem of awareness. 46 of them, they are not aware that their condition, and 26% only this time is measured their BP. World Heart Day, it's done in 22, 24, and 25. More than 17 Libyan cities involved, 500 volunteers. In last one, اللي هو 2025, 18 teams participated, reaching to more than 3,000 and supported by 295 volunteers. Let's Fast Healthy campaign 2024 and 2025. Every time we reach it, the people, we have a problem in detecting the hypertension. So 47% they had hypertension and unaware was 12.2. Guideline development to increase public awareness 2025, we have 3 guidelines. One for healthy life, for fast, healthy, for elevated and hypertension patient, national guidance for physical activity and guidance for healthy. Guidance for fast Ramadan, healthy for elevated and hypertension patient. This is already published in CDC online. It's a practical evidence-based guide to help people with hypertension to maintain healthy lifestyle and fast safety during Ramadan, emphasizing medical assessment before fasting at least 3 weeks before Ramadan, professional advice during and after Ramadan, maintaining optimal cardiovascular health. Libyan physical activity guidance. Mission develop national evidence-based physical activity guidance adapted to Libyan context to raise awareness and promote active living. الأول طبعاً خلاص نزلنا على موقع NCDC التو guidance اللي هم النيوتريشنال والفيزيكال activity إن شاء الله حيكونوا في نهاية السنة جاهزات. بالنسبة للليبيان نيوتريشنال جايد الجنرال goal to guide individual and community toward healthy, balanced diets suited to local culture and resources, improving public health in Libya. For doctor building capacity, update 2018 guidance for management hypertension in primary health care to clinical approach to managing elevated blood pressure and hypertension in adult primary health care setting Libya 2025. طبعا هذا الابروش اللي اندار في 2018 من الاسم نتاعه يعني even the title is changes to elevated blood pressure. Nowadays we don't talk only for hypertension but also elevated hypertension is a risk factor for cardiovascular disease and must be controlled. What's new in the update? Definition and classification of elevated blood pressure and hypertension, emphasize confirmation of diagnosis and standardized BP measurement technique, educational resources for correct BP measurement, training video موجود على موقع جمعية القلب الليبية اليوتيوب. cardiovascular risk assessment using score 2 score OB للأول ما كانش فيه السكور 2 score OB for cardiovascular risk stratification and statin therapy. Use patient-central approach, which also new communication with hypertension diagnosis, illness representation and initial treatment. Simplified treatment protocol for elevated BP and hypertension. في خطوات ماشية كيف نتعامل مع elevated hypertension, elevated BP. Management of hypertensive patient during special religious occasion such as Ramadan fasting, Hajj, Umrah, promoting healthy lifestyle practice, safe fasting and optimal blood pressure control. اللي على اليمين هذا كان البروتوكول الأول وهذا الأبديت اللي هو استخدمنا فيه اللي هم الكومباينيشن ثيرابي as initiation first line treatment. In researchers we have estimation salt intake using 24-hour urine collection. A result that means salt intake in Libyan population using 24-hour urine collection is 9.12, which is high than recommended by WHO. This one can be used to later on as a baseline to support the future evaluation. Evaluation metric, prevalence and control of hypertension, dyslipidemia, diabetes, smoking and obesity rate, trend of cardiovascular morbidity and mortality. Home message, prevention is cornerstone for reducing morbidity and morbidity for cardiovascular disease. It's achieved through major risk factor control, particularly hypertension, early detection, update, evidence-based management. Prevention is shared responsibility from global level, United Nations, WHO, to national level governance, professional society, civil organization, and public, and down to individual. Evidence-based guidelines are essential for effective prevention, and public awareness through direct media channel is vital. Capacity building with health system and communities remain the key priority. Recommendation, translate strategy and plan into action, support awareness campaign, strengthening surveillance and screening program, promote and support researchers, empower and support volunteer. This is the most important one. Foster multidisciplinary collaboration. From plan to action, we have many strategies by WHO. Thank you for all.
هو الخير حين
في فيديو للفولنتيرز نشوفوه في اللاست وورد هارت داي.
هو الخير
شكرا لكل من ساهم في البريفنشن through all the campaign.
كلفتات ود بنفس محبة ولمسات قلب بكف رحيمة، وماذا سوى الخير يعطي بريقا لجوهرنا ذا جمال.
Thank you very much, Dr. Hawa. That was great. So we have covered up the pavement of the way for hypertension management. We've seen the magnitude of the problems of hypertension in our societies and the great effort with our volunteers and different societies and team to help. It's given me my pleasure to introduce our next speaker, where she will cover a little bit about another risk factor, which is diabetes. He will talk about the diabetes management, what every cardiologist should know. It's my pleasure to introduce Dr. Adila Al-Mami. Dr. Adila, she is a professor of internal medicine, endocrinology department at Al-Hawari Hospital, and a member of Libyan Diabetes Society, and a member of higher committed training of the Libyan Board of Internal Medicine, and a member of European Society of Endocrinology. She is an expert to talk about diabetes and the burden and what us cardiologists need to know about it. Thank you.
Assalamu alaikum. So my talk will be, first of all, I would like to thank the scientific committee of CARDIOLIBYA 11 for inviting me to talk about diabetes management, what every cardiologist should know. I have no relevant disclosures, and my talk is totally human. There is no AI contribution. My agenda will cover the glycemic goals, any new in glycemic goals, and the outline of screening of diabetes and for cardiovascular disease. And we will outline the newer management algorithm, which is related to cardiovascular prevention and cardiovascular disease and the risk management in diabetic patient, and then we'll summarize my talk. If you look to the glycemic goals, we always depend on A1C and self-monitoring blood glucose. But now, with the introduction of continuous glucose monitoring, we have a newer metric, which is the time range. And now, CGM is indicated even in type 2 diabetic patients who is not using insulin. Previously was approved in type 1 diabetes patient, but now even type 2 without insulin. And the time range, which is recommended by all the guidelines, is 70 to 180, should be more than 70%. and the hyperglycemic range should less than 30%, and the hypoglycemic range should be less than 5%. Why we introduce the time and range? Because we see many patients with the A1C, similar A1C, less than 7, but they have, some of them, they have complication because simply they have a variability. When you look to the time and range in these two patients, you can see one with a very severe hypo and hyperglycemia, and these patients, they are prone to complications. The other thing, we move to more to individualized of target. In a patient, in general patient, we recommend less than 7, but if the patient have less risk of hypoglycemia, a short duration of diabetes, he doesn't have any established cardiovascular disease, with drugs which have a cardiovascular and kidney benefit, in these patients, we can go even less than 6.5. While in a patient who has a long duration of diabetes, he has established cardiovascular disease, he has a high risk of hypoglycemia, and they use drugs which have a non-glycemic benefit. In these patients, we can accept even less than 7.5 and less than 8. So don't surprise when diabetologists, they keep an A1C less than 8, that's maybe safe for the patient. In some patients, we don't depend on A1C at all because these patients, they have a limited life expectancy, so we just prevent hyperglycemia and hypoglycemia. What about the screening? Still, most of the guidelines, they don't recommend a routine screening for coronary artery disease unless the patient have symptoms and signs or have additional vascular disease like hypertension or ECG abnormality. In that time, we screen the patient. For heart failure, now most of the guidelines, they recommend to screen for stage B heart failure by using the measurement of BNP or internal pro-BNP. If any one of these parameters is high, you should refer your patient to echocardiography. For peripheral vascular disease, the recommendation nearly the same. We recommend to screen patients age 65 or more if they have a foot disease or microvascular or organ damage, or if the bad diagnosis can't change the management, or the duration of diabetes. Some even they recommend if the duration of diabetes 10 years or more, you recommend to screen the patient. And the screening tools is using the ankle brachial index. What about the management, the cardiovascular disease and the management? Still, the lifestyle and lifestyle modifications and diabetes education is the cornerstone of management of diabetes. And in addition to glycemic management, we should add blood pressure control, lipid control, and addition of drugs which have a benefit on cardiovascular and kidney disease, even regardless of glycemic control. So you may add drugs even if the A1C is controlled. So the 4 pillars of management. And even if you look to the algorithm, which is the newer algorithm by the ADA 2025, they look for the goals. So if the goal was to control the cardiovascular in a patient with a high risk for cardiovascular or kidney disease, so for example, if the patient have established cardiovascular disease or he has a high risk for cardiovascular disease, in these patients, we should start either GLP-1 receptor agonist with proven cardiovascular benefit, or SGL2 inhibitors with proven cardiovascular benefit. So it's the first choice, even before metformin. There is no metformin here. And if the patient is still uncontrolled, you add the other drug. For example, if you start SGL2, you can add GLP-1. And if the patient is still uncontrolled, you add bioglitazone. Why bioglitazone? Because bioglitazone shows a cardiovascular risk reduction. If the patient have heart failure, the first choice is SGL2 inhibitors, which proved to have a heart failure benefit. If still the patient needs control, you go for GLP-1 agonist with proven cardiovascular benefit. And avoid drugs like bioglitazone in this situation because the patient, because bioglitazone can exacerbate heart failure symptoms. If the patient have a CKD and estimated GFR is less than 60 or the albumin creatinine ratio is more than 30. In this patient, we start ACE and ARBs, and after maximize ACE and ARBs, you start SGL2 inhibitors for both, for glycemic control and for reduce the progression of kidney disease. And if it is still need and control, you add GLP-1 agonist with proven cardiovascular benefit. So in this algorithm, you can see the metformin. So metformin becomes more and more not the first line therapy. If the goal was weight management, you start with GLP-1 agonist, which had high efficacy and weight reductions. There is some drugs with a very high efficacy like semaglutide and tirzepatide, Ozempic and Mounjaro, and we have dulaglutide and liraglutide. If the patient have they need a moderate or high, just high or moderate efficacy. If you don't have any one of these drugs, for example, patient financially he can't afford for GLP-1 agonist, you go for SGL2 inhibitors because SGL2 can reduce the weight. If it's still the patient have afford or he needs and control, you add drug which cannot induce weight gain, like DPP-4 or metformin. So we don't go for sulfonylurea or insulin because these two drugs can increase the weight. If the benefit or the goal was only glycemic control, in that way we can start metformin, which is the last line. Metformin alone or can be added to other therapy. And remember to delay the need for sulfonylurea and insulin in most of the algorithm, unless the patient just for glycemic control. So the newer for algorithm that metformin is not the first choice. Don't surprise to see patient on SGL2 alone as a first line therapy or GLP-1 agonist. What about the hypertension in diabetic patients? Blood pressure should be checked every visit, which is every 3 months, or at least every 6 months if you can check every visit. Diagnosis of hypertension and diabetes when the patient have 2 readings at least in separate occasions, 130, 80 or more. But if the patient have established cardiovascular disease, diabetic with established cardiovascular disease, with a blood pressure 180, 110, one single reading is enough. The target is to keep the systolic blood pressure less than 130 and diastolic less than 80 without significant postural hypotension. If the blood pressure is elevated, like Dr. Hawa say that elevated blood pressure is very important now, more than 120/80, start non-pharmacological therapy with a DASH regime. If blood pressure is 130/180 but still less than 150/90, we start with, in addition to lifestyle, one drug therapy, single drug therapy, depending on the presence or absence of albuminuria or CAD. If it is present, ACE and ARBs is the first choice. If blood pressure is 150/90 or more, you start dual therapy, combination therapy, depending again on albuminuria and CAD. If present, you should start ACE or ARBs in addition to CCB or diuretic. If there is no albuminuria or CAD, you can choose any combinations. But the concept of combination is important in any diabetic with 150/90 blood pressure. If still the patient is uncontrolled, you add the other drug which is not added before. If it's still uncontrolled, you add mineralocorticoid receptor antagonist. If the patient is still uncontrolled, you should refer the patient to blood pressure or expert in blood pressure management. If the patient is intolerant, you change the drug therapy. If he is controlled, you continue with the therapy. What about the lipid management? If the diabetic patient is between the age of 20 and 39, you may consider statin therapy if he has an additional cardiovascular risk factor, for example, diabetic and hypertensive. If it is 40 to 75, you start moderate intensity statin. If he doesn't have any additional cardiovascular risk factor, if he has additional of at least one cardiovascular risk factor, you start high intensity statins, and the target LDL is less than 70. If the patient is intolerant to statins, you start bempedoic acid. If there is still a need of additional therapy after statin or maximum dose statins, you add the BCSK inhibitors or ezetimibe. BCSK inhibitor is not available in Libya, at least in Benghazi, but we have ezetimibe. In people above 75, if he is on statins, continue statin therapy. If he is not in statin therapy, you may discuss the benefit and the risk with the patient, and then you start moderate intensity statins. What about secondary prevention, lipid management and secondary prevention? We start on high intensity statins, keeping an LDL less than 55. If it's still in need of addition of therapy, ezetimibe or BCSK inhibitors. If the patient intolerant to statins, you start BCSK with monoclonal antibody treatment, or bempedoic acid, or BCSK plus small interfering RNA, اللي هو inclisiran. So ADA is recommending inclisiran only in secondary prevention. What about the antiplatelet management? For secondary prevention, still aspirin is the strongly recommended as secondary prevention. Individuals who are allergic to aspirin, we can start clopidogrel, but they add that you can use aspirin plus low-dose rivaroxaban in a patient with a stable coronary artery disease and peripheral artery disease if they have a low risk of bleeding, to prevent major adverse limb and cardiovascular events. So if your patient have a low risk for bleeding, you can combine aspirin plus rivaroxaban. What about primary prevention? The ADA recommend aspirin in a special situation. In diabetic patient with having high risk for cardiovascular disease, you may consider aspirin 75 to 116(2). So take-home message. CGM can be used in a type 2 diabetes patient, even not in insulin therapy. So we should be aware about time and range as a metric. More toward individualization of glycemic targets, especially in patients with established cardiovascular disease and comorbidity. Screening for stage B heart failure with the BMB and anti-pro-BMB is recommended in all diabetic patients with a high risk for heart failure. Pharmacotherapy now looking beyond the glycemic control, and multifactorial approach for prevention of cardiovascular risk is very crucial. So discussion between diabetologists and cardiologists is very important. Thank you for your attention. I will add one thing that hopefully Dr. Hawa, she talked about the guideline protocol for hypertension. We have an, alhamdulillah, guideline for diabetes, still not finished, but يعني alhamdulillah بدأت في one step and aided by WHO. Thank you.
Thank you very much, Dr. Adila, for this nice presentation. You have collected the cardiologists and made them familiar with what they should do with diabetic patients and vice versa. So we are going to move now to another interesting lecture, and going to be performed by Dr. Ahmed Al-Gabroun, who is the Professor of Internal Medicine and Cardiology, Medical Director, United Medical Center, Mohammed bin Rashid University of Medicine and Health Science at UAE. The topic of presentation that he's going to deliver also a very interesting topic in this regard, that is the cardiac conditions and screening in athletics, ensuring heart health in sports, which will be very, very interesting to us. Floor is yours, Doctor.
Thank you, Dr. Nasruddin. Thank you, my colleagues. And actually, again, thanks for the Libyan Society of Cardiology for inviting us for this conference. It's my pleasure to be here for the third time at the conference, and it's really interesting to interact with people and to know more and to learn more about our country. It was interesting that in our prevention session today, we cover about hypertension and diabetes as both them as of great risk factors. When we go to the root cause, it's a lifestyle. We always say lifestyle is the main root cause for all cardiovascular diseases. So the way how we eat, the way how we live, how active we are is the basis of our developing atherosclerosis and heart failure and all of cardiovascular diseases. But the balance comes here when people start to do exercise and they suffer cardiac injuries or they have some risk of cardiovascular disease, especially when it comes to somebody who is athletes, running, doing exercise every day, but all of a sudden we hear that he arrested or he has a cardiac issues. What's going on? What's wrong? You tell us, go and do exercise, and at the end I have heart problems. I've got one quick question for all the audience, please. Just to know, like for the audience, how many of you is engaged in regular exercise? I mean, at least 3 times per week. Can you raise your hands? Regular exercises? Okay. Unfortunately, we know that. I mean, always, like less than 25% of the people are really engaged in regular exercise of 3 times a week. We're looking for 150 minutes per week. Unfortunately, the number is low. But is there a risk of doing exercise? Yes, if we don't check. So this is my title, actually, is that to screen people when it comes to cardiovascular disease. Again, I have no disclosures. My agenda, I would like to cover the importance of cardiac health in athletes. People are doing exercise. How important to check their heart and make sure that they are fine? Is it common? Are we really having a common cardiac condition affecting athletes, people at exercise? What are the symptoms and warning signs of cardiac issues? Is there something that can tell us that, take care, this person is doing exercise, but there is something going on and there is a risk? What are the screening protocols we need to use for cardiac condition in athletes? And what are the challenges, controversies in cardiac screening? Is there any management protocols, preventive strategies to prevent cardiac events in sport people? Emerging technology, future direction to help to screen and to find cardiac diseases, and some case study from the real world applications. So it's really important to know about the cardiac condition. As we know, cardiac health matters for athletes' performance. The healthier the heart, the more healthier the person. People who go and do exercise, whatever the exercise, they build muscles, they strengthen themselves, but as we know, the most important muscle is the myocardium. The stronger the myocardium, the better for their performance. Not only that, it's important for their recovery. They need to recover after exercise. But the most important thing is that they may be at risk of sudden cardiac death during exercise and recovery if we don't screen them for the potential causes. Is it common? Incidence of cardiac condition, it is important to know, as it is common in athletes if we don't screen for it. The incidence rate varies. Understanding increasing rate of cardiac helps develop effective screening protocol for athletes, and there is some preventive measures. So prevention and screening always plays a target role here. As per statistics, we know that sudden cardiac death occurs in approximately 1 in every 50,000 to 200,000 young athletes annually, with higher rates in males and certain ethnic population, and most of the event unfortunately happen during or immediately after intense physical exertion. At the beach, in the gym, while they're exercising, that's the time where they have the events. The age is a younger, productive people, younger ages, usually between 15 to 35, and majority of them are males, where 5 to 10 higher risk in males participating in active sport. So it's a high-profile case and public awareness. It attracts a lot of medias. It needs a lot of public awareness about it. So cardiac event in athletes is something that we need to screen. It's not that very common, but it can bring a lot of attention. And we know that if somebody is a football player or a bodybuilder all of a sudden dies during activity, can bring a lot of attention. And here comes the importance of public awareness and campaigns. So what are the common cardiac conditions we need to screen for and we need to know about them? So basically there is some of them which is structural heart disease, some of them are high risk factors, some of them are electrical issues, and there's some red flags. The commonest structural heart diseases I'm going to talk about quickly is hypertrophic cardiomyopathies, right ventricular cardiomyopathies, and congenital coronary anomalies. Electrical disorders like long QT syndromes, WBWs, cataminergic polymorphic VT, some high-risk features, abnormal ECG patterns, reduced ejection fraction, or inducible arrhythmia on testing. Some clinical red flags, remember to family history of sudden death, exertion and syncope, chest pain, or palpitation. Athletes doing exercise regularly coming with those red flags, take it serious. What's hypertrophic cardiomyopathy? I'm not going to go in detail about it. It needs days and lectures to talk about it, but generally, it is the hypertrophy of the septum which affect the flow of the blood from the LVOT to the aorta. When it causes obstruction, it can cause sudden death, and it mainly affects young people and athletes. It cannot be diagnosed until a screening done by ECG plus minus an echo. The other one is arrhythmogenic right ventricular cardiomyopathy, and this has a genetic basis where the right ventricle becomes a focus for generating ventricular arrhythmias, and that can lead to sudden cardiac arrhythmias and death. Next is the congenital or acquired coronary artery anomalies, where we have abnormal origin of the right or the left coronary in between the pulmonary or an aorta, and during exercise with high pressure, it might obstruct the left main or the right coronary, leading to acute myocardial infarction and sudden cardiac arrest. What are the symptoms and warning signs of cardiac issues in athletes? As I said, syncope can be one of the first commonest. Somebody running all of a sudden falls down. He or she needs to really be screened and looking for the cause of it. Chest pains. A young man, young woman doing exercise, all of a sudden start experiencing sudden chest pain while exercising, can be a significant and worth investigation. Palpitation. All of us, we feel fast heart rate while exercising. But if these palpitations are persisting and troubling the patients, then it's worth to be investigated. Sudden cardiac arrest in sports is something prevalent in young athletes, as we said. Its importance for risk awareness. There is emerging response preparation. So having a proper screening, public campaigns, and availability and preparation for sudden cardiac arrest like AEDs and training of person around the sport person. Family history plays an important role. As I mentioned, some of the causes are genetic. So any history of sudden cardiac death or syncope in the family, it's worth investigating and looking for a relative of those patients to screen for cause for the cardiac death. So there is different screening protocols and condition structured by different international societies to screen athletes. And in fact, now there is sport cardiology section where people are investigating, are running and doing research and creating protocol and guidelines for athletes. First, we have to do pre-participation physical examination. All elite athletes, people are really involved in exercise in daily performance, they need to have pre-participation physical examination. And as we know, for example, football player, all of them, they have to go to the FIFA screening form. They have to go through a long process of screening to make sure that they are fit before they start their career. Assessing their cardiac history and looking for any symptoms which might alert, as I mentioned, for cardiac issue. Baseline ECG is very, very important, where we might see an abnormality, as I mentioned, long QT syndrome, WBW features, prolonged PR, peak T waves. All those things might alert you for presence of cardiovascular issue behind the ECG. Echocardiography plays again an important role. If you feel that you are comfortable and you want to screen the patient further, then echo can rule out hypertrophic cardiomyopathy, poor ejection fraction, valvular heart disease, and here, based on that, you might decide to go further for advanced imaging. So as I said, echocardiography is a structural assessment. If you are in doubt, you can go looking for scars by doing cardiac MRI for tissue characterization. And in some patients, if you're suspecting coronary anomaly, you might do a CT coronary angiogram to check for any coronary flow abnormality like bridging, myocardial bridge, or anomalies of the origin. In other patients, we might go further to do electrophysiology with long monitoring, exercise testing, and focus detection of the arrhythmia. In genetic testing, we screen people who are at high risk, especially with family history of sudden death. What are the challenges, controversies in cardiac screening? Usually the cost effectiveness is the first thing. Some people, they might say the test is not available or it's very costly to do, but at least a baseline ECG, I think something is affordable, and most of the patients who are involved in exercise, they should have a baseline ECG as a screening tool to look for their further fitness for this. Ethical consideration, as we know, especially for high professional athletes who are high salary paid football clubs, when you tell them that you have a heart issue and you might be not able to continue performing, it could be an ethical issue where consideration about the future career of that athlete. He or she cannot perform anymore as he used to be. So confidentiality, ethical implication can play an important role in decision when it comes to athletes' life and support. Management and prevention strategies, it varies, depends on the usual, as we're always saying, lifestyle modification, exercise, diet, stress management helps improve cardiac health and prevent complication. In some patients, we might need to start them on medication, especially like if we find that they are hypertensive, hypoglycemic states, diabetics, hyperlipidemics. In some cases, we need to do surgical intervention, as I said, anomalous coronaries or valvular heart disease, where we have to screen them and then send them for surgery. What is the international guidelines comparison? We have variations. We know that in HA, American Association, they have a 14-point personal and family history checkup. They do a regular physical examination for all athletes, and they selective ECG uses. Where the European Society of Cardiology, they have a mandatory ECG screening, family history assessment, regular follow-up protocols depends on the patient. And as I said, there is national variation. Implementation varies from country to country, depending on their health system and health delivery. Education and emergency preparedness is very, very important to have. After cardiac risk assessment and awareness, emergency action plan. If something happens, what we have to do. People need to be aware about how to do the CPR, how to use defibrillator, and how to assess the nearest hospital to provide the patient's care. Emerging technology and future direction, we know now that there is so many advancement in following and monitoring people, and now most of the athletes who are professional, they have a long-term 24 hours, or during the competitions, they have wearable devices to monitor their pulse, blood pressure, body temperature. All parameters are under monitoring. And maybe some of you have seen that the football player, now they're all wearing special belts where they are all monitoring during the activity of their exercise. Early abnormality detection by screening and physical examination. We have also an AI wearable devices where like they can detect and see any alerting arrhythmias. Genetic screening and precision medicine in some high-risk patients where we know that we may not need to do further investigation to screen them for genetic cause of their cardiac condition. There is so many international recommendation and research areas where we know sharing knowledge, doing research about athletes, and creating a guidelines fits the country is something that we're looking for to have in our area. It's a teamwork. It needs everybody around that. So the cardiologist, the sport medicine specialist, the trainer themselves are part of the management of the athletes. So it's a team approach. We sit together, we discuss the case. So the trainer who is daily with the athletes, family, people around him, the cardiologist, the family physician, and the sport medicine specialist, we sit, discuss the case, how far we can go with exercise with that athletes or not. So in conclusion, it's important of awareness about this. Raising awareness about cardiac health is crucial to prevent risk in athletes during sport activity. Screening and management are important. Regular cardiac screening and proper management helps detect and address heart condition early in athletes. Advanced technology can help with including monitoring and detecting condition of the patients. Thank you very much.
Thank you, Dr. Ahmed. Very interesting, attractive, and successful presentation, actually. So now we are going to open the discussions for almost 20 minutes. Before doing that, I will phrase a sentence from Professor Christian Bernard, the surgeon from South Africa, who performed the first world successful heart transplantation on 1967. He performed that. If I would like that prevention could prevent many diseases, many heart diseases, I would focus on prevention, not in surgery. So I still admire that professor, what he said, and today actually the prevention method and the prevention issues in this regard, it is very, very important and crucial at the same time. So now we are going to move to questions from esteemed participants. Before we proceed with the questions, I would like to announce that after discussion, the lunch break will be held here inside the hall, along with the speech from two companies going to proceed with their speech. So the lunch will be in the hall, inside the hall.
Okay. So it's now the floor open for questions. If anybody from the audience wants to question, if nobody could start, yes?
Thank you for this opportunity. We had great talks, especially about hypertension, but I think the whole world is now defining hypertension as systolic blood pressure over 130. And they also are starting aggressively treating hypertension by starting combination therapy if the lifestyle modification failed by ARBs and diuretics. So are we 1 step or 5 steps back from the updated guidelines, especially the American and Canadian guidelines? Thank you.
Yes.
Thank you for your question. Still, the lifestyle is the cornerstone of the treatment of hypertension. Still, in any step, even the algorithm, you will find the first line is lifestyle. You mean what's the classification of blood pressure? Okay, we have elevated blood pressure. Any blood pressure over or equal 120 over 70, this is elevated blood pressure. Once the patient have 140 or more over 90, he's a hypertension. We have the new classification is elevated blood pressure according to 2024 European Society of Cardiology. As a Libyan Cardiac Society, يعني احنا تابعين للأوروبيان Society of Cardiology. We are member. So what they said, we are يعني نفس التعريف اللي هم حياخدوه نحن حناخده. بالنسبة للأمريكان هارت أسوسيشن من مدة كانت 130 على 80. هذا هي the first يعني احنا كنا نقوله مثلا من زمان يعني 130 على 80 هذا هايبرتنشن. بس توا النيو كاتيجوري اللي هو الاليفيتد بلاد بريشر. الريسك سكور هو اللي بيحسب لك هل البيشن هو يعني انت عندك عده سكورات بتستخدمها تحسب الريسك سكور وبعدين ادد ريسك. هل هذه مثلا فيميل، هل عندها سكور هل عندها ريسك ثاني مثلا ستيل بيرث وهيك، هذا يدير لك اب سكور. حتى لو كانت هي لو ريسك حتصبح في الهاي ريسك. يعني انا حنتبع الاذر ريسك فاكتور باش نشوف الريسك وين البيشنه هي.
I think there is another question has been submitted by the doctor concerning what you said that some diuretics, something like that. What about diuretics? They are not starting as a combination. When the diuretics are less than 140, you mean? When the diuretics were less than 140 for systolic and less than 90 for diastolic? 130. Is your question that why we should not start with diuretics? Okay, if Dr. Hawa allow me to answer this question, please. So, it's not recommended to start with the sorry, Dr. Hawa?
شو السؤال معلش؟
The combination therapy. He said that the combination therapy, they start with 130 over 90 with combination therapy. They start with combination therapy, dual therapy, for
Yes,
example.
we start with low dose. If you, according to we personalize the patient. In a frail patient or in elevated blood pressure, you can start with single drug therapy. But once the patient is 140 over 90 or over, yani he is hypertension, the combination therapy is now the mandatory. But we can modify our treatment personalize it according to our patient.
Okay, if I can just follow the, okay, if I can just with one comment, Dr. Hawa, concerning this regard. Usually when the readings around 130 over 85 up to 90 or something like that, modification of lifestyle is mandatory to be implemented. However, when the numbers are higher than this reading, so one school or two schools, they ignore that the importance of lifestyle intervention, despite it is important in all classes. In this class, for example, this is class number 1. When you consider 140 something, don't push yourself don't push your patient very aggressively towards combination therapy. This is my own opinion, Dr. Hawa. And as all of you know, when dealing with hypertension, it is experience-based practice. Many people they are very happy with agents now. They are not used anymore, but they are very happy with it. When you follow with the guidelines, it's okay. Dual therapy or combination therapy in certain population with comorbidities, for example, something like that. Even 140, sometimes you need them for prevention. When there is competing indication and prevention, dual therapy, you might need them. So it depends on the readings and the adjuvant symptoms along with.
هو في حاجة دكتور نصر الدين، احنا عندنا asymptomatic اللي هي hypertensive mediated organ damage. يعني once انك انت تلقى يعني this is indication انك انت البيشنت تبدا لايف ستايل تراجع عليه 3 شهور اذا كانت his blood pressure still high, his score 2 OP is high.
Yes.
This patient, he needs the treatment.
He needs, yes.
He needs.
Of course,
Even when his blood pressure is elevated, يعني he is not diagnosed as hypertension. But this is in guideline evidence based, يعني هم حاطينها level A، يعني مش احنا اللي اخترعناها.
No, I'm agree with you.
We followed evidence based medicine.
هو
في recommendation.
إن 130/80 if he has added cardiovascular risk factor. حتى diabetes is added risk factor يعني.
Yes.
Even diabetic combination therapy only in 150/90 or more. You know, if you give a combination, take care that the patient will develop sometimes postural hypertension. 130/80 usually one single therapy in addition to lifestyle, because lifestyle is very important. Whenever you have 150/90, you can go for combination therapy if the patient is not controlled. Or even if controlled in lifestyle. The guideline 150/90 in 2 separate occasions, you go for combination. But 130/80, one single therapy in addition to lifestyle. Or if the patient have,
also can we start by single therapy. Even الكومباين ثيرابي في البروتوكول نتاعنا بادين، يعني احنا في البرايمري هيلث كير you can start by half dose، يعني مش الفول دوز بتاع الكومباين ثيرابي. احنا عارفين ان ليش يعني القصه نتاع الكومباين ثيرابي انك انت تشتغل عليه اكثر من مكان يتحكم في الهايبرتنشن. ف we can start with half dose، وهذا اللي ماشيين في البروتوكول. يعني باش انام في البرايمري هيلث كير يقول انا مش قادر نبدا بالحبه كامله، وهي موجوده في الخيارات نتاع الهارت باكج، يعني موضوعه يعني برضو الهارت باكج، يعني ممكن 4 مؤسسات هم اللي حاطين الخيارات اللي ممكن نتبعوها كبروتوكولات علميه.
Thank you, Dr. Hawa. Yes.
سؤال الدكتور محمد هاشم، بالنسبه للكاسبسانا بلوكرز واخدين بس الاملوديبين والنيفيديبين، يعني انا تركتوا الادويه الحديثه زي الزانيديب وما زال الايزوبتين والدلتيازيم. والسؤال الثاني، هل يطبق هذا في بروتوكول بالنسبه للهايبرتنشن بريجنانسي واللاكتيشن؟
شكرا دكتور. زي ما وضحت انا في البرزنتيشن ان ان هذا تريتمنت بروتوكول للبرايمري هيلث كير. هو باش ما نعقدوش الامور على الجنرال براكتيشنرز، ان الاوبشنز اللي تكون عندهم تكون واضحه وستريت فورورد. طبعا الغرض من تريتمنت بروتوكول مش فيزيشن اورينتد بس، او حتى هو ديسيجن ميكر. يعني وزاره الصحه، جهاز الامداد الطبي، انا باش نقنع يوفر لي علاج لمريض الضغط نحاول ندير له ليميتد اوبشنز من التريتمنت، ونخلي الادفانسد ولا الموست ريسنت جنريشنز عند السكندري كير، عند التيرشري كير، عند السبيشلايزد سنتر. فديما نركزوا احنا في البرايمري هيلث كير ان المانجمنت يكون بسيط، لان في الاخير الفيزيشن اللي في البرايمري هيلث كير هو مش كارديولوجيست باش نوفر لنا الفرايتي كلها. هذا بالنسبه للسؤال الاول. ودائما تريتمنت بروتوكول يعني يتراجع كل سنه كل سنتين، ممكن تضاف حاجات ثانيه على حسب نقول الوضع الاقتصادي للبلاد، على حسب الوضع السياسي الصحي للبلاد، فهذا يعتمد. الشيء الثاني ما نبيش نخلي الفيزيشن يوصف ادويه ادفانسد على مستوى البرايمري هيلث كير، ونخلي الاوبشن اللي احنا نقول الريزيستنت هايبرتنشن والكومبليكيتد كيسز للسكندري كير والتيرشري كير. بالنسبه للبريجنسي هايبرتنشن احنا فضلنا ما يكونش على مستوى البرايمري هيلث كير، ان هذه اشياء تكون على مستوى السكندري كير افضل شيء، لان فيها زي ما قلت انا في عندي جابس اللي عندي مثلا على سبيل المثال الكرياتينين غير مش متوفر عندي في البرايمري هيلث كير، انا مش حتى نتبع به الهايبرتنسيف بيشنت، فلا بالك يكون عندنا البريجنسي هايبرتنشن اللي هو فيه الريسك بتاع البريكلامسيا والكومبليكيشن والحاجات هذه. فلذلك فضلنا ان تكون عند مستوى السكندري كير التيرشري كير بين السبيشلايزد سنتر سواء كان كارديولوجي او الاوبستاتريك كير.
عفوا دكتور هاشم، معلش نزيد نعقب على كلامه. يعني فعلا اللي قاله دكتور هاشم، احنا علاش تريتمنت بروتوكول البرايمري هيلث كير راهم ما همش كارديولوجيست، they deal with many diseases. يعني هو مسؤول على الكونفولجن، مسؤول على يعني ممكن حياته لو نسألوا حد في القاعة على تريتمنت اللي يعني نطلع شوية من الكارديولوجي حنكون شوية على الأقل ما نقولوش احنا ان ابديت. فالمشكلة البرايمري هيلث كير انه يتعامل مع عدة حالات، يعني هو مش حيكون في كل شيء. فلما ندير لتريتمنت بروتوكول الجوريثم سهل يمشي به، يعني نختار مثلا من احنا الدراجز نفسهم هم كلاس يعني يشتغلوا بنفس الكيفيه. لو اخترت انا 1 دراج او 2 دراجز، اول حاجه في الافوردابيلتي بيكون سهل. يعني لو تشوفوا احنا الدراسات اللي اندارت كلها في ليبيا كانت المشكله نتاعنا ان اليوم حتلقى اللوزرتان، بكره حتلقى الزستريل، بعد بكره حتلقى الميكاردس. هذا حتخلي البيشن نوت ادهر للتريتمنت، ما عندناش ادهرنس للتريتمنت. افوردابيلتي مهمه. انا لو وفرت الدواء نوعين حنسهل، او قلت انا الادويه هي نبي منها الكلاس هو نبي منها 2 بس، حنسهل على الدوله انها تشتري، يعني احنا الامداد الطبي يشتريه لنا، وهذا مهم في البرايمري هيلث كير. سهلت على الطبيب انه هو كيف يعني يختار الدواء المناسب ويمشي به. احنا عندنا مشكله في الادويه زي ما قلت انا في محاضرتي، كانت الادويه اللي هي النمطيه الاساسيه غير موجوده، وهذا حاولنا ان احنا في امبلمنتيشن في الهارت باكج ان نختاروا حتى شنو هي الادويه الاساسيه. كان في شويه تعارض من الكارديولوجيست ان احنا لا انا ما نبيش نحدد دواء معين، يعني ما نقدرش نحدد دواء البلدان الاخرى اللي دارت امبلمنتيشن للهارت باكج اختارت دواء واحد، يعني مثلا على سبيل المثال اللي هو اختارت الفالزرتان باش هي تمشي به. فهذا بيسهل على اللي هو في الرعاية الصحية الأولية أن يعطي الدواء صحيح في الدوزة الصحيحة، يسهل على الدولة أنها هي الشراء توفره. يعني هذه الفكرة من التريتمنت بروتوكول يبدأ سهل، وهذا يسهل علينا احنا يعني جميعا ان احنا نديروا كنترول للهايبرتنشن والكارديوفاسكولار ديسيز. يعني الامباكت حتكون على ان سي دي سي كلها.
Interesting one. I mean, we can see that the challenges are too much. Whether we are talking about hypertension, diabetes, lifestyle, challenges are there. The guideline is there. Research already show us that there's evidence, there's guidelines to start whatever medication, but always there's a gap. Always there's a gap how to implement this. And challenge with regard of availability of the medication, that cost, the education, they're always there. I think, Doctor, you have a scenario of a case where you would like to share with us.
Yeah, actually, I have a scenario or a case presentation actually that is that might open the discussion more friendly and more scientifically. There's a case of urethral hydronephrosis. The patient was 68, female, 67 or 68 years old. She presented to nephrology department with ascites, flank pain, anemic with 5 gram per deciliter. And the decision was made to, and her BP was 225/125. So what is the management? How they would start with? Urethral hydronephrosis, flank pain, ascites, high BP, and anemic. Any answer? This is actually the gap between the protocols and the experience-based practice, how to deal with this type of very complicated cases. On regular hemodialysis, 3 times or 4 times per week for 3 to 4 hours. So, no. Floor is yours, all of you. No, I don't like this sinus, actually. We don't like this sinus. Please go ahead with the intervention. How can you manipulate this case? How can you manipulate it?
Can you tell us your opinion, doctor? There is no one. What do you think about it?
Okay, such type of cases, actually, the anemic has reverse directions of benefit against risk. While the patient is anemic, it means that the blood pressure will never goes down. Still will goes up. Here we think about blood transfusion. Okay, blood transfusion cannot be performed while the blood pressure is very high. So what we are going to do? They are going to reduce blood pressure very normally, and they should not deal with this case like normal patient. She is on hemodialysis, renal failure. I forgot something that also she has a sigmoid, cancer sigmoid. She operated, and the dilemma starts here. What to start and how can we start? The people over there, actually their experience tell them, I don't know, they started with her orally, captopril, which is absolutely 100% contraindicated. And they started also orally with calcium channel blocker, amlodipine. It is also not there. It should not be listed. It is good, but not orally. In this case, we have to manage my patients or our patients by parenterally, IV. And that time, and that day, the patient was presented for more than 8 hours and blood pressure has not let down because of pharmacokinetic and pharmacodynamic changes and because of the nephrotic. So the idea is not to touch your patients orally when she is in this sort of concomitant comorbidities. IV and IV and IV.
I think this shows exactly what we are talking about is team approach. I mean, when we have a patient who are complicated, multiple comorbidities are there, and the guidelines is there to guide you for 1, 2, 3. We know what we do for simple cases, general public patients. But when it comes to complicated cases, here the team approach plays a very important. So having a nephrologist, diabetologist, cardiologist, general physicians, all together, sitting together if we can, and discuss the case as a team approach can help to decide what is the next for the patient, keeping the patient in focus in the middle of the story. Thank you very much. Any other questions, any other comments from the audience before we close this session? Yeah, I mean, I think it was covered already for Dr. Hashim. I mean, for the guidelines, as we know that it's always there is a challenge when implementing it. So let's talk about our national level in Libya itself. We have the guidelines international, we can create our guidelines. What you're talking about is excellent, is how to implement it. You mentioned the challenges. Is there any solutions, ideas from WHO or from our national stakeholder or decision maker, how we can overtake those challenges? I know it's a big question, it takes days to answer, but...
Actually, the answer is simple in one word, but to implement it's complex. We call it in WHO governance. You need strong legislations. If we're going to agree on the treatment protocol, this have to be disseminated at the level of district health authorities. Let's say Tripoli, Benghazi. They have a treatment protocol, but the big challenge is the chain supply for the contents within the treatment protocol, for the items, for the medicine. Once you provide medicines, then you need to provide the diagnostic and equipment, which is simple also at the same time. So if you manage to provide at the level of decision makers, at the level of Minister of Health, if you ensure the continuity of the chain supply for medicines and the continuities for equipment and diagnostic, then this is the biggest challenge. The second challenge is capacity building, is disseminating the treatment protocol. It's enforcing primary healthcare physicians the trust how they can diagnose and manage hypertension until step 6, where then they need to refer the patient for secondary or tertiary specialized centers.
هي سابقا يعني كان عندنا تجربة سابقة، فكان الابروش تو مانج الهايبرتنشن في البرايمري هيلث كير اللي ندار بالان سي دي سي، وكان معنا الليبيان كارديك سوسايتي والرعاية الصحية الأولية. فتم تدريب، كان مستهدف 1000 طبيب. يعني الابروش هو كان سهل يعني براكتيكال. طبعا الكومبليكيتد كيسز اللي تو زي يتكلم عليها دكتور نصر الدين، هذا مش شغل البرايمري هيلث كير، يعني بريجننت ليدي اللي هم الكرونيك كيدني ديسيز، كل الكومبليكيتد هادو كان يصير لهم ريفيرال. لكن احنا نحكوا عن الناس اللي هي العاديه اللي هي عندها الهايبرتنشن. تم تدريبهم عن طريق الخدمات الصحيه طرابلس، وكانت تجربه كويسه، يعني ان في عدد من الكارديولوجيست تبنى الموضوع. يعني كان على ان مش ينعطوا المحاضرات بس هاو تو ابروش البيشن، لكن كان بعدها ان يتابعوا الاطباء، هما تيم مدايرين وعندهم من يستعينوا به. يعني هذا في طرابلس وقفت التدريبات هي بسبب الحرب. احنا تو عندنا مؤسسة الرعاية الصحية الأولية، مش عارفة دكتورة عبير كان حاضرة، فهذه صراحة يعني واحدة من المؤسسات اللي هي واخدة على عاتقها أنها تدريب الأطباء اللي في الرعاية الصحية الأولية. وإحنا يعني في تعاون ما بين سواء المركز الوطني WHO الرعاية الصحية، كل ستاك هولدر مهمين ان احنا باش نرفع الاويرنس نتاع الاطباء ومقدمين الرعاية.
شكرا دكتورة حوا.
Great. So thank you very much. I think it was very interactive and fruitful session. We discussed so many things, and thank you for your audience and for your patience. I think now is the next for the industry symposium. Dr.
Yes, thank you very much, Dr. Ahmed. Once again, the lunch will be carried here, inshallah, inside our, as I told you previously. And at the same time, two companies are going to deliver their speeches concerning what they have in their minds. We will start with شركة الخبرات الدوائية وشركة النور الذهبية. If any representatives of these two companies, sorry? No, في لبدا. الاناونسمنت جاني من لبدا. Yeah, scientific sessions we have finished them, but the two companies they should start their session here in Libdas. So nobody from شركة الخبرات الدوائية or neither. I think one is there. شركة الخبرات شركة النور. No, if it is no, so we will close this session. Hopefully that the other sessions will be very promising and very attractive as well. And thank you for your patience, and thank you for your cooperation, and for your questions, and thank you for the presenters for their attractive lectures. Thank you all. اوكي الساده الافاضل، في تنويه من السيد ان الدكتور محمد تير going to present شركه الخبرات speech after 10 minutes. فحيكون هنا ان شاء الله after 10 minutes or within 10 minutes. دكتور محمد حيجي هنا، والمفروض حسب الكنترول ان اللانش حيكون هنا المفروض. لا تقريبا خلي هنا. اوكي، السلام عليكم ورحمه الله وبركاته مره اخرى. نفسح المجال الان للساده شركه النور الذهبيه to deliver their speech. الدكتور محمد المشري ان شاء الله is going to represent the company. Wish him all the best and the company all the best. تفضل دكتور محمد.
Thanks, Doctor. It's truly our pleasure to be here and very honored to be here for first time with Noor al-Dhahabiyya company, which officially representative the Sudair pharmaceutical company. It's short duration in Libyan market, but long duration with the Saudi Arabia market and the Middle East, with a partnership with United States American experts and the pharmacology experts. Sudair Pharma in the cardiology we choose two products. One of them I want to mention for, and the other one I want to give him with many details. Let's start with Apixaban, treat, product, and reassure. As in WAX in the last years, the recommendation going to recommended with Apixaban more than Rivaroxaban, with many trials and many studies mention it for the duration working or mechanism of action, safety and efficacy. It's more with Apixaban. So this is the VTE causes. All of them here know about the causes, but their risk factor developing increase in the VTE after major surgery, after major injury, in case of cancer, and in case of heart attack. And this is the important point. The epidemiology slide, this is in the KSA, affects a large population annually, approximately 25,000 patients annually in KSA, and can be recurrent with 10% recurrent rate at 12 months. Can be fatal, yeah, can be fatal with the rate 10% to 12%. The mechanism of action for Apixaban SPC is a reversible, highly direct selective inhibitor of factor 10, and directly inhibit platelet aggregation induced by thrombin, and we all know about this cascade from the graduation year. Approved indication, Apixaban SPC is used for patients who have undergone elective hip or knee replacement surgery, and I think here we face conflict with our colleagues in the orthopedics. Many of the physicians in the orthopedics department still, as an old school, use enoxaparin and other unfractionated heparin. So we have the conflict here for the Apixaban. Vice versa, for the cardiologist with Apixaban is a smoothly used and effective use with the patient, specifically in the non-valvular atrial fibrillation. Treatment and prevention of recurrent DVT and BE. This is the big trial for non-valvular atrial fibrillation, AVERSE trial, Apixaban versus acetyl salicylic acid to prevent stroke in atrial fibrillation patients who have failed or are unsuitable for vitamin K antagonist treatment. We talk about the more than 5,000 patients in this sample, 5,599. I don't know about the last one, maybe left this study. Double blind with atrial fibrillation with risk factor 1 or more, and demonstrated or expected unsuitable for vitamin K antagonist. 36 countries this is a trial, and more than 500 centers. 2 groups with Apixaban, and the other group, one group with Apixaban, another group with aspirin, 81 to 324 milligram per day, and follow-up for the patient. Apixaban significantly reduced the risk of stroke or systemic embolism by almost 55% for patients with atrial fibrillation versus 2 aspirin, and this is big number. Aristotle trial versus warfarin in patient with atrial fibrillation. This is the biggest one in the studies make it in the world. Aristotle trial, 18,201 patients in 39 countries, more than 1,000 centers. Include the patient more than 75 years, peristroke, TIA or SE, or with HFrEF, or diabetes, mellitus, and hypertension. Double-blind in this study, or the sample, with two groups. One group with apixaban 5 milligram BID, another group with warfarin target INR 2 to 3, and the primary outcome was to stroke or primary systemic embolism event. Here, the conclusion: apixaban SBC significantly reduces the risk of stroke or systemic embolism by almost 21% for patients with atrial fibrillation. Again, non-valvular atrial fibrillation decreased the risk of major bleeding by 31% versus warfarin. Here, with the dosing for non-valvular atrial fibrillation patients, apixaban SBC has consistent and convenient dosing regimen. No dose modification is required in most of the population. No INR monitoring is required as warfarin. No dietary restriction can be taken with or without food. We're talking about the 5 milligram twice a daily. This is the recommended dose. There is adjustment dose, yes, 2.5 milligram for a 3 characteristic adjustment dose, aging more than 80 or less than 60 kilograms, or creatinine more than 1.5. This is the adjustment dose criteria for apixaban. This is amplified trial for VTE, oral apixaban for the treatment of acute venous thromboembolism patient with DVT or BE and DVT. Apixaban with 10 milligram twice daily for 7 days, then and next week for at least 6 months with 5 milligram twice a daily. And another group, enoxaparin every 12 hours for 5 or more days, and warfarin INR was target between 2 to 3 and the INR numbers. Here the conclusion: decrease the risk of recurrent symptomatic VTE or VTE-related death by 16% versus conventional therapy. Also decrease the risk of major bleeding events by 69%, and this is the big number in this study or in this trial versus conventional therapy. Amplified trial, oral apixaban for the treatment of acute venous thromboembolism, efficacy and safety outcomes. As we see, apixaban dosing for VTE patient has conventional dosing regimen. No dose modification again is required in the most of the population. No INR monitoring is required. No dietary restriction can be taken with or without food. In this part of VTE, 10 milligram twice daily in the 1 week or the first week, then followed by 5 milligram for at least 6 months. This is for our colleagues in the orthopedic department, and I think we'll escape this slide, hip and knee replacement, talking about it in the ADVANCE 2 trial and ADVANCE 3 trial. I think we escaped this part. Extend use, amplify, extend trial, apixaban for extended treatment of venous thromboembolism. In this study, more than 2,000 sample of the people, clinical diagnosis of DVT or PE, anticoagulation treatment 6 to 12 months, no recurrence. A group with apixaban and a group with the placebo, follow up at 12 months. In conclusion, apixaban SBC decreased the risk of VTE recurrence or death by more than 64%. And again, this is the big number for this trial, and last trials we mentioned it before, when used extendedly for VTE patients who completed at least 6 months of anticoagulation treatment versus placebo. Amplify extended trial, again, apixaban for extended treatment of venous thromboembolism. We mentioned it here for safety, no significant increase in measure of CRNM bleeding rate with the extended use of apixaban SBC. This is the side effect, maybe mention it with courage in this trial, common in anemia, thrombocytopenia when used apixaban with overdose, hemorrhage, hematoma, epistaxis, and common maybe mentioned for pleuritis, brain hemorrhage, and hepoptysis. In this summary, be confident to treat apixaban SBC effectively simplifies to treat of VTE, product effectively secures thromboprophylaxis, and usage is not associated with increased risk of the bleeding. And finally, extended use of apixaban SBC effectively secures thromboprophylaxis. This is 10 minutes as we have here with the organizers. Thank you for listening, and I hope enjoyment with this lecture. Thank you.
السلام عليكم ورحمة الله وبركاته. بنرحب بحضراتكم وبنشكركم على الحضور الكريم. أنا اسمي محمد السقا، ماركتينج دايركتور لشركة الخبرات الدوائية فارمكس، ويشرفنا ويسعدنا إن احنا نكون متواجدين مع حضراتكم، ويشرفنا إن احنا نقدم الأستاذ الدكتور محمد التير. دكتور محمد سينيور انترفنشنال كارديولوجيست ان معتيجة هوسبيتال. تفضل دكتور محمد.
السلام عليكم ورحمة الله. Thanks دكتور محمد. شكرا لشركة الخبرات على إتاحتهم الفرصة لي for this presentation, which is quite important for hypertensive patients. And our talk today will be more on telmisartan and amlodipine combination. We'll go step by step. Well, I think we have enough time. So, as we know, all hypertension is a risk factor for cardiovascular disease. And when you look in more details, like here, for cardiovascular death worldwide, hypertension ranks the first among the 10 other cardiovascular risk factors. And this is, again, evidence from a study, which is a prospective cohort, enrolling more than 150,000 patients from 21 countries. So it's quite representative of different populations, and 14 risk factors looked at. And still, hypertensive is a major and main cause of cardiovascular disease, stroke, cardiovascular death, and second to dyslipidemia for MI. And those patients being followed for 10 years, so it's quite a long time. In 2019, this is data from WHO, and published in Lancet. Between age of 30 to 79, either male or female, throughout the world, there was more than 1 billion patients with hypertension, meaning the blood pressure more than 140 over 90. So it's a quite large number of people we're dealing with. As you see, the different countries had different incidence of hypertension, prevalence of hypertension, from 16% over to 50% in some countries. And the problem with hypertension, it's as you can see here, this study showed that, WHO organization did this surveillance, and they found that 1.4 billion affected with hypertension, 40% to 45 were undiagnosed. So diagnosis was like more than 55% of those patients. And not only that, when you look at the treatment, there were like 25% untreated of those who were diagnosed. And in more detail, when you look at the control, it's become worse, when like maybe 50% were controlled. So this leaves us with every 5 hypertensive patients, there's only 1 that is diagnosed properly, treated, and followed up correctly. So it's still a large problem we're dealing with. In terms of the obstacles that we deal with, there are different levels when you want to start program for hypertension screening, prevention screening, treatment, and follow-up. And we can divide those factors into personal level, individual level, program level and policy level, political level. So for individuals, to take an example, for prevention, sometimes lack of knowledge about hypertension, why we look for hypertension, what is the hypertension. So we need to educate our people about those issues. And then why do we screen for hypertension? As patients, people need to know about that, the benefit of screening for hypertension. We know there are financial constraints sometimes, geographical constraints, somebody who is far away from medical facility, and the cost of it as well, and the more there. So when you have hypertension, why we treat it? Why we treat it? This is important. Patients that think they have no symptoms, blood pressure of 140 or 190, 170, over 110, they have no symptom whatsoever. That's why we call it the silent killer. So patients, they don't have symptoms, they don't think they're sick. And majority of them, in fact, asymptomatic. So education is very critical, very, very critical here. And we need to also to try to convince patients that even if you have to pay some money to get treatment, it's worthy. It's going to stop you from getting strokes, MIs, etc. And then we start your treatment. It's not the end of story. You need to follow up your blood pressure as well. One tablet sometimes not enough. You need to follow those tablets, if they're effective or not. If you have any side effects, then we got to tell them as well, we expect you to have cough from this or have leg swelling. So patients, they don't leave the medication just because they don't know about those side effects. So, and the program level, it's very important that we train our staff, our nurses, our primary health physicians, that they need to know why we screen for hypertension, why we want to treat hypertension, and to orientate the resources probably at the primary health facilities for such a endemic problem. For policy level, which is a political, obviously it's a political decision, we need to convince our politics that this is a major problem, carries a lot of consequences, and in productive age group between 30 years of age till 79 years of age. If you have a stroke at 40 years of age, you're going to deal up with family, expenses, medical therapy, aspiration, etc. Treating one patient with tablet is much better than having those patients with strokes in stroke unit or disabled in rehabilitation units. So it's very important to know that there are some problems, but we can deal with them if we have the right intention and we the right approach to do. In Libya, as you see here, we have probably more prevalence of hypertension than the rest of the world. So we end up like 39% of Libyans between age of 30 and 79 have hypertension by definition, and only half of those being diagnosed. As I told you, it's asymptomatic, and they don't check their blood pressure. They don't know. They have headaches, they go home, they rest, they sleep, they wake up, and then only 1/3 of those were treated. So half diagnosed, 1/3 treated, and controlled is about 12%. It's a quite very, very low figure, despite the knowledge of is going to be hypertension is the highest risk factor of cardiovascular disease and cardiovascular mortality. Okay, hypertension doesn't come by itself. So as you see here, if you have a hypertensive patient, half of them might be dyslipidemic. So you need to do a lipid profile, okay? 1/3 of them might be diabetic as well. Obesity is another problem. Patients who are dyslipidemic, 60% or 65% being hypertensive. Obviously, overweight is a problem here as well, and diabetes. Comparing to when we have diabetes, 3/4 of these patients, diabetic patients, are hypertensive. So you have a diabetic patient, you make sure that you follow up the blood pressure. It's a quite large number of them will be hypertensive as well, and this is the effect of diabetes and kidney add to that hypertension. So you need to look careful for hypertension in those patients, and obviously diabetes associated with obesity. We all know that. So the hypertension and diabetes and those risk factors. If you have 2 risk factors, it doesn't mean you're going to have double your risk, but they are multiplicative, not just adding the risk. You're multiplying the risk. For example, if you're diabetic, the odds ratio of increased total CV risk is about 2.5 times. But if you have 4 risk factors and hypertension, or 3 risk factors with hypertension, the CV risk goes to 20-fold or more than 20-fold. So it's not just addition, it's multiplying or factor of multiplication here. So it's important that we control those risk factors well. So these are just the guidelines for management of hypertension, the International Society of Hypertension, the European Hypertensive Society, and so on. All guidelines recommend that we individualize treatment to every patient. Not every patient is the same. Okay, the choice of antihypertensive treatment should be based on morbidity and mortality prevention, obviously. You have to control blood pressure early, very important for outcome, because the IUs to come, not just when you're 2. And try to simplify regimens, very important. To give the patient 1 tablet instead of 2 is much better for compliance, okay? So the guidelines agree on those issues, that this medication should be well tolerated. If they have side effect, change the medication. It's not a problem with that. You have low lymphedema, you still can use ACE inhibitor or ARBs, you can use calcium or diuretic. So changing the medication to the in relation to the side effects is very important. You have to use medicine that is accessible to patient they can find it, and it's affordable as well. The cost is not very high. This is critical for adhering to treatment. We need to educate our patients. This is obviously paramount to whatever we do. And periodic regular monitoring is very, very important. So we look at Mr. Saleh, who is a 58 gentleman, merchant, father of 3 children, and soon expecting his first grandson. Reason for consultation is intermittent headache, resistant to analgesias, which began several weeks ago. So his medical background, his father died at the age of 52 from a myocardial infarction. This is a family history of MI. He's active smoker, so the second risk factor. He's diabetic on 10 years now, poorly monitored, and he's treated with metformin twice daily. His cholesterol treated with atorvastatin, 10 milligram per day. So his clinical examination was blood pressure read averaging 165 to 95. We all agree this is high reading. Probably this is the reason for the headaches. And then his heart rate is normal. The rest of exams are remarkable. Physical examination or paraclinical examination. ECG is in sinus rhythm. There are features of LVH, which is a marker of chronic hypertensive heart disease, and ambulatory blood pressure monitoring confirmed hypertension and non-Deber phenotype. We'll look into that. His fundi were normal. So he's got target organ damage in form of LVH, but his eyes are okay. Okay. So biological assessment, his fasting glucose, 1.49. His HbA1c is quite high at 8%. His triglycerides 2.4, that's also elevated, and LDL is quite high as well. So his GFR is 57 mil per minute, and he's got microalbuminuria. So he's got target organ damage in form of LVH and renal involvement as well. So, no, so this one shouldn't play. No, it's supposed to be a question anyway. So therapeutic management in this patient would be dietary and lifestyle measures plus physical activity. I think we all agree on this. Anybody objecting on this? Metformin, he's been taking on 1 gram twice daily, plus Imba, 2 milligram once daily, atorvastatin 40 milligram, and also we added telmicor amlodipine, which is telmisartan amlodipine combination, 40 milligram over 5 milligram, 1 tablet per day. Any objection on this treatment? We agree on this. There's nothing wrong with this, okay? So we're trying to control his blood pressure, which is high. We started 2 agents in one go. We increased his atorvastatin to 40. 10 is a quite small dose. His levels were not controlled. And his HbA1c was quite high. Then we added EMPA for that as well. And obviously lifestyle modification is important for every patient. So the problem list, this patient is hypertensive. We say it's a grade 2, stage 1, stage 2, and stage 3. So he lies in category 2. And whenever we see hypertension patients, so the guidelines recommend the first line therapeutic options will be ACE inhibitor or ARB, diuretic, or calcium channel blocker. Either one of these three you can choose, but they recommend first step to start with dual. Start diuretic or calcium channel blocker or ACE inhibitor, calcium channel blocker. And then if you don't control the blood pressure yet, you add a third agent. So if you have 2 agents, the chance of controlling blood pressure will be like 60%. And if you add third agent, then your blood pressure might be controlled out 90% at a time. So we end up with a very small amount, which is 5% of patients will be classified as resistant hypertension. So, but before you label this patient as resistant hypertension, you make sure that they are taking the medication. They'll be in 3 agents at least. One of them is diuretic. If they're still having high blood pressure, then they'll be labeled as resistant hypertensive patients. Sometimes we admit patients to hospital to see what's going on, to make sure they're taking the tablets. There are subgroups which are, you might start one agent in elderly patients, patients with very high risk, patients like somebody with stage 4, 5 CKD, and you don't want to go up with very high dose of ACE inhibitor, then maybe you start on, and diuretic might be a problem as well. So you imagine those patients, might you start with one agent, small dose like telmisartan 40, and then see what happens, and then if they tolerate it, you go higher. Or patients with, for example, for heart failure patients and hypertensive patients, maybe you have to add beta blocker, which is anti-remodeling therapy as well. So there are certain indications for specific medication. Or anginal patients, you add beta blocker or calcium channel blocker. So you can use other medications rather than those 3 just to help you treat your patients. Okay, so for telmisartan, amlodipine combination, it's winning. So we've seen this is data showing that regardless the stage of hypertension, whether stage 1, stage 2, stage 3, telmisartan combination with hypertension with the amlodipine still works better. So if you see here, the worse the blood pressure, the more the effect. So which is, we do have a tablet of 40 over 5 and 80 over 10 as well, and we have or 85 or 80-10, so 4 combination we can use. For, as you can see here in more detail, for stage 2 hypertension, which is probably, some people call it malignant hypertension, if you use the dose of 80 and 10 milligram, still you have good control or good drop in systolic blood pressure by 50 millimercury. So that's a good achievement. We don't see that only in a single risk factor, like patients who are hypertensive, but also we see this works with diabetics across the spectrum, high BMIs, metabolic phenotype, elderly patients, regardless of the race, severe hypertension. You still gain a lot by using this combination on those patients, average of 45 to almost 50 millimercury reduction in blood pressure. Again, if you compare telmisartan, amlodipine combination to other ARBs combinations like irbesartan or amlodipine, still telmisartan supersedes other ARBs with more effect on a blood pressure. And obviously, this study now in more than 14,000 patients, and this meta-analysis was done in 32 randomized controlled trials, so it's a quite large amount of patients. Don't look at the percentage, but if you put it at millions of patients, it becomes very, very significant, the difference. Okay, so we're back to our patient. So he is non-taper phenotype. We all know there's a normal variation of hypertension during the night, during the day. So during the night, blood pressure goes down, and early morning goes up, and then dips down again. So our patient was like the non-taper, so he's the green line, as we see here. And which has been published a few years ago, I mean 2005 this. So if you have night hypertension, there's more risk of cardiovascular death at 5 years. Okay, so night hypertension is not good, either diastolic or systolic, regardless. Night hypertension is not a great thing to have. So we wanted to control this, obviously, okay. So again, patients on endeavor, the CV risk mortality, as you see here, is twice 2.5 ratio, gives you twice the normal, or more than twice the normal risk. Okay, telmisartan and amlodipine, combination of these two, they have the longest half-lives, as you can see here across, telmisartan across the other ARBs, amlodipine across the other calcium channel blockers. And they can cover your patient for 24 hours. So amlodipine is usually even certainly 100% covered, goes to 30 hours half-life, and telmisartan still more than other ARBs from 70 to 100%. And it's important to note that early morning hours where the cardiovascular events are higher, this is where you want to control your blood pressure. And those two medication works very well in this early, in this period of time. So again, we're going to discuss the issue of arterial stiffness, which is a new concept or been a while in literature. The older you are, the more stiff your arteries. And the measure clinically, when you have systolic or peripheral pulse pressure more than or equal to 60 millimercury. When you get systolic and diastolic, you get more than or equal to 60 mercury difference, okay? Arterial stiffness is lost with age, as I said. You know, when ventricular contraction happens and relaxes, generates a pulse wave. And if your artery is elastic, then it will damp those pulse waves. You will not be able to record them with high velocity. But if they are stiffer, those pulses will not be dampened by the arterial wall. And there are few risk factors for increased arterial stiffness. Age is one of them, but probably genetic, socioeconomic, lifestyle, and other risk factors of cardiovascular disease like hypertension, diabetes, and etc. As I told you here, if you look this graph, the systolic pressure goes higher and the diastolic goes down as we age and our artery is more stiff. So CD1, which is normal aorta this side, and that's the abnormal. It has nothing to do with calcification. Calcification is something else. This is the arterial wall, the elastic fragmentation or elastic fiber change that makes your arteries more stiff. And also it does cause like remodeling effect on the ventricle in terms of hypertrophy and myocardial fibrosis. So increased arterial stiffness is not a benign thing. If you look at this meta-analysis of 17 longitudinal studies of almost 16,000 patients for 8 years almost, so the more stiffer the arteries, the risk of total CV events increases, CV mortality increases, and all-cause mortality increases as well. So it's a quite non-benign condition to have. So again, this is a measure, I think, done in China, where they look at arterial stiffness by itself and arterial stiffness with hypertension, and what is the outcome. So the green line is the normal one, so reference 1, this is normal. Then if you have hypertension with no arterial stiffness, your ratio for composite outcome, stroke, myocardial, non-fatal MI, or cause death becomes 1.1 almost. If you look the higher part, which is the orange one, hypertension with elevated arterial stiffness, it doubles the risk of those composite endpoints. So definitely it's not a benign thing. So arterial stiffness is also a relative or multiplicative risk factor. So it's been added into guidelines as well. They measure it with pulse wave velocity between brachial ankle or cardiac ankle index. So it's non-invasive measure to do, okay. The effect on main classes on arterial stiffness, as you see here, beta blocker and beta blocker, and diuretics probably don't have any effect. This side of the diagram, and the ACE and calcium channel blockers, they do have effect on arterial stiffness, so they improve arterial stiffness and outcome in those patients with arterial stiffness. Even after they adjusted the bottom one, they adjusted a multivariate, but still confirming that those medications, the ACE inhibitors and calcium channel blockers, they improved the outcome in these patients by reducing arterial stiffness somehow. But the effect is more pronounced with telmisartan. As you can see here in this data, telmisartan decreases the arterial stiffness much more than other ARBs. Obviously, valsartan has some effect as well, but telmisartan ranks the first. Okay, back to our problem list. So very high cardiovascular risk level. This is our patient. He's got diabetes, target organ damage, hypertensive, dyslipidemic, arterial stiffness, non-DAPR. Okay, so again, kidney injury, and those patients, our patient, his creatinine was, his GFR was like 45 to 59 milli per minute, and he's got macroalbuminuria as well. So he's a quite high-risk patient. So this study in New England Medical Journal compared telmisartan, ramipril, or both in patients with high-risk cardiovascular events. Either you give telmisartan, ramipril, or both, and see the outcome. Okay, so on-target study, it's more than 150,000 patients, a quite large study. Okay, so what they did here, it's a double-blinded dummy study, and parallel groups, they divide into three. Either you take telmisartan 80 milligram per day, ramipril 10 milligram, which is a full dose, or you combine telmisartan and ramipril and look, over a period of 4.5 years. Again, this is just the inclusion criteria. Most of them were diabetics as well. So about 3,000 more diabetics, okay. And what they found that this is proving that telmisartan is non-inferior to either ramipril or the two combination. So you can just use telmisartan, you get the same effect, okay. So at relative risk of 1, it was almost non-inferior to ramipril. Before, I think the nephrologist is more concerned about ARB is not effective in kidney and preventing kidney proteinuria and so on, but now data showed that they are effective. So telmisartan is one of them that you can use on those patients. Telmisartan, again, this is another study just to show you that it's not inferior to ACE in terms of cardiovascular protection. Again, telmisartan comparing to other ARBs. This is a meta-analysis done to look at cumulative risk and CV cumulative risk, and then my stroke, hospitalization, heart failure, telmisartan proven to be more effective than other ARBs. Amlodipine, and compared to other calcium channel blockers, also proven to be superior, and this has been shown in 4 trials involving 60,000 individuals. Some of them are hypertensive, others are non-hypertensive, still chooses cardiovascular issues. So amlodipine also winning either in hypertensive or non-hypertensive. And there's just a clinical trial where the telmisartan been used. So busy slide, don't worry about that. Just tell you that telmisartan has been used in a lot of kidney patients, different stages. It has been proven to be effective, okay. Telmisartan is similar efficacy compared to ACE inhibitor on the primary renal endpoint in patients with high cardiovascular risk. So this is, again, non-inferiority. Telmisartan and ramipril alone, or combined, so telmisartan is still good to go with. Again, in terms of proteinuria prevention, telmisartan is better than ramipril. Comparing one-to-one comparison, telmisartan is better than ramipril for 2 years outcome in terms of proteinuria reduction. Okay, proven efficacy on macroalbuminuria. So we're comparing here telmisartan and irbesartan. Irbesartan, you have one dose of 150 and 300 milligrams. Telmisartan, we have 80, 40, and irbesartan 150 and 300 milligrams. What you see here on the graph, that's an innovation. Telmisartan, whether 40 or 80, it's effective. Irbesartan, 150 and 300 milligram, there's a quite some difference in between the doses. So meaning that you can get good effect with 40 telmisartan. You don't have to go to 80. But irbesartan, you need to go to 300 milligrams to be fully effective. So telmisartan, and this dose is, I mean, if we have somebody who's like just came in the hospital with high creatinine and you don't know about the baseline and the proteinuric, you start telmisartan 40 and see how it goes, because it's effective as 80. Instead of starting 150 and going to 300, just 40 milligram telmisartan will be enough for those patients. And you don't worry about doubling the dose and causing probably more renal issues. I don't know if that's clear. It's a clinical point. Again, reducing proteinuria in patients with diabetic nephropathy. So if you have a patient with diabetic nephropathy, established diabetic nephropathy, telmisartan still works compared to losartan. So you can use telmisartan in those patients as well. Okay. And this is now a study showed that telmisartan in managing diabetics with chronic kidney disease, and they found that telmisartan lowers the transition rate to overt nephropathy. So if you have stage 2 nephropathy, telmisartan prevents your patient from going to stage 4 nephropathy or stage 5 nephropathy. This is at 1 year follow-up. And again, telmisartan also significantly reduces blood pressure levels. Okay, again, telmisartan is also effective in delaying the progression to overt nephropathy. So it does treat nephropathy, slow progression for nephropathy, as well as prevents nephropathy. So you get win-win situation anyway. So back to our patient, what we have done to our patient, I think we all agree it's a true. Sorry. Almost done one. Okay. Okay, it's working, Doctor. Okay. So just 1 minute more, we're finishing. So telmisartan amlodipine. We have got 4 combinations, the 45, 85, and I think among the ones that maybe you use, we're going to use more commonly in diabetic patients, the 40 over 10 as comparable to other ARBs, and then we have the 80 over 10 milligrams as well, so we have 4 combinations. And the 14 is quite new. Again, take-home messages, telmisartan being proven to be effective in hypertensive patients, particularly among high-risk patients. Telmisartan, they're also effective against variable blood pressures. They reduce your nocturnal blood pressure as well effectively. Telmisartan being outstanding efficacy in arterial stiffness, proven to be effective as well. And telmisartan there seems to be a perfect combination and for cardiovascular protection and renal protection. So you get win-win situation. And thank you for your time. Any questions? Yeah. Yes, yes.
Thank you, Dr. Mohammed. Thank you very much for this presentation. I have a question concerning its role in CCU, in those patients with current myocardial infarction. If you would like to compare it with the ACE inhibitors, it is comparative, as you have shown us. You have shown us it is very comparative. So does it have a sort of specificity towards expansion from infarct size, like what ACE inhibitor is doing, concerning also post-MI, concerning the remodeling as well?
Very good question, Doc. It's the guidelines, by definition, they ask you to go for ACE inhibitors first. If they're intolerant, you go to ARBs.
Yes.
So in terms of heart failure management. So yes. I don't think we have enough data to say the guidelines recommend that ACE, then ARBs, or maybe Sacriptal valsartan.
Usually people they are preferring S inhibitors in SSU, specifically during the MI itself.
I understand. I mean, valsartan had a lot of trial being done on stems of heart failure.
Okay.
And not telmisartan. Telmisartan is more hypertensive oriented than valsartan, which is more cardiac oriented. So the studies in valsartan more than in telmisartan in heart failure.
So the positive side will be towards the hypertension control.
Yes,
control
more. But there's no data saying no, you can't use it. No, you can. I mean, there's no data say you cannot use telmisartan in place of valsartan in place of irbesartan in heart failure. Yeah. They're all comparable, but the data in heart failure is more in valsartan. That's why you see the renin inhibitor combined with valsartan. Okay. You see what I'm saying? You don't have it with irbesartan.
Okay.
You see so that's the data.
Okay.
Yeah.
Thank you very much.
No, it's a pleasure. Any more? Yeah, like we.